Devi is the candidate.
Dr. Noor, is it a video or a picture?
Can you play it?
It's a picture. This child is a newborn who is in the NICU, who's got these vitals which have been shown. And
Okay.
this child is like almost now going on the ventilator. I just imagine he's on the ventilator. I'm not getting videos and now I don't have the time to search, you know.
Okay, okay. Okay.
So just see the readings, see the neonate, and once you are ready, we'll start. I have set the time 3 minutes.
The day of life, anything?
The day of life is day 1. This child
Day
is
one.
just a 12 to 18-hour-old newborn. Okay, this saturation, and now he's being put on the ventilator. We had discussed this last time, but we had discussed another DD of this. Today we'll discuss another DD.
Okay, last time you were there, Dr. Devi.
No, no.
Okay.
This case I didn't see. Yeah.
Okay, you can start.
Please describe the findings, doctor, that you have seen.
Okay, so today I saw the video about day 1 baby, around 12 to 18 hours of life. Baby is in hospital setting. I cannot see any dysmorphic features on the face. The baby is attached to the ventilator, also with the IV cannulation. And child is, there is some, in this picture I can see some like cyanosis of the lips. But maybe on ventilator it is difficult to comment. And otherwise, mostly baby is on maybe in distress. Yeah, this is my initial this thing. And on exam, baby is also attached to the monitor with the heart rate of 157 per minute, with respiration rate of 49 per minute and saturation of 53%. But I don't know whether this monitor is attached to upper limb or lower limb. Yeah,
very good.
These are the findings I can see. So if any distress, I will comment on that. And any other anomalies in the upper limb, lower limb, those also I will try to comment if anything.
What will you ask on the history?
In the history, I would like to start from the antenatal history, whether a mother had any problem and whether baby is term or preterm, mode of delivery, and whether, and antenatally if she had any problem like any hypertension, any diabetes, any fever, any rash, was she on any medications? This history I would like to take. And at birth, I would like to know about the prematurity term or preterm, the weight of the baby, whether baby required any resuscitation, and upcars. Yeah.
Okay. And what will you examine in this baby?
On examination, I would like to do complete vitals, including the forelimb saturation, forelimb blood pressure, and also the capillary refilling time, other heart rate and all I can see in the monitor. And then I would examine from head to toe examination to look for any, I will start from the anterior fontanelle.
What exactly, which saturations would you like to see?
Sorry?
Which saturations would you exactly like to see?
Right upper limb saturation I will see, preductal, and also I will compare with the postductal saturation.
So how will you interpret that?
That is, if saturation is more than 3% difference, then it is significant.
Okay.
And the upper limb saturation should be above 95% at least. Yeah.
You said forelimb blood pressure. So, what is the
Sorry?
What is the difference between the upper limb and lower limb blood pressure?
Blood pressure, ideally it is less than 15 millimeter, but if it is more than 20, it is significant.
Which blood pressure is higher, upper limb or lower limb normally?
Normally, upper limb will be higher than the lower limb.
Please go ahead.
Okay. Then head to toe examination, I would like to check the, because child is 6, so anterior fontanelle I will check, then the eyes to look for the pupillary reaction. Then I will check the chest, mainly the cardiovascular examination and respiratory examination. for this child. Also check the temperature in this child for hypo and hypothermia, and abdomen for any organomegaly. And yeah, and I would like to plot weight, height in the weight and length in the growth chart.
How will you what are the differentials that you have for this child?
For this child,
Newborn.
as child is cyanotic, so I would like to put first possibility as day 1 presented. If child is not having much respiratory distress, I will put a cyanotic congenital heart disease first. Second is maybe primary pulmonary hypertension, and third, very important also, any respiratory illness, like first sepsis and other respiratory illness like pneumonia, any meconium aspiration syndrome, if preterm respiratory distress syndrome. So these possibility I will keep, and very rarely newborn also can present with pneumothorax.
Oh, fine.
Yeah.
So how will you manage this child if this is a child of what investigations would you like?
Yeah, first of all, I would like to do the routine investigation, complete blood count, CBC, CRP, procalcitonin blood cultures, then blood sugar,
Which
electrolytes.
inflammatory marker will come first, procalcitonin or CRP?
Procalcitonin.
How many hours it will be positive if it is sepsis?
Usually, it comes immediately within 8 hours.
Okay, fine. Now please go ahead.
Okay, then urea electrolytes and also ABG, blood gas is important, lactate. And also chest X-ray, echocardiography. Yeah, this investigation.
Very good. So in echocardiography, you come to know this is PPHN. How will you manage this case?
Okay, so PPHN cases basically we need to minimal handling should be there initially, and
Very
initial
good.
if required ABC airway breathing circulation is the most important for any case. So that is already been done for this child, already on ventilator. So yeah,
I think the time is up, but that's we'll continue. Dr.
Okay, then minimal handling of the child is very important, and light should be not too much. Then later other thing is medications can be tried, sildenafil has been tried in these children, and sometimes
does sildenafil have any evidence-based role now in PPHN?
I'm not sure about it. Okay, and then other medications sometimes I think this nitric oxide, later, yeah, they use this. That is actually proven
Go by
treatment in
ABC,
PPHN.
Dr.
Yeah.
Sri.
I told airway breathing. I told already airway breathing
so
circulation,
airway,
and as already child is into.
Supports.
Sorry?
So explain the higher supports of airway and breathing.
Yeah. This I told as airway breathing circulation is to be taken care of as the child is on ventilator already mostly started on
Okay, so
it
if
has
he's
been
not
taken care of.
ventilator, then what do we?
Yeah.
What options of other ventilatory management we have?
Yeah, other ventilatory management, if it is routine, it's not working, they can go for high frequency ventilation, and yeah.
Very good.
Yeah.
Then after that, if it's still not working,
then I'm not sure. I think it is ECMO.
Yeah, quite right.
Inhalation nitric oxide, then ECMO. Yeah. So what is the criteria for ECMO? Any idea? Even ECMO sometimes comes as videos.
Dr. Muzna, there is some problem in your speech. It's breaking. Just check
it's right. It's now fine. I'll take my laptop close to me. Yeah.
Yeah.
So,
go ahead.
Okay, fine. So criteria of ECMO by any chance?
ECMO is indicated if the routine ventilation is not working, and we need to give rest to the lungs. Lung is ventilation perfusion mismatch is going on, so they have to give rest to the lungs. So in that case, they go for ECMO.
Can I do ECMO in a 28-weeker?
28-weeker. No, I don't know.
Okay. Alhamdulillah, nicely done, Devi. So I'll actually this video was done last time, I think, with Dr. Satish, and same till the differential it was the same, and that we had told to manage as a cardiac case. So now this time we just thought that if any examiner thinks of not going to the cardiac case and thinks of discussing PPHN, so Dr. Noor and I thought that we should even discuss about complete the discussion of PPHN also. Otherwise, generally for this case which have come, the Viva will go on prostaglandins, dinoproston, side effects, and what are the this last time also we had discussed about which are the heart diseases which will present at this time. So we will not discuss all that right now because we have already discussed. I will just say a few points. You have Alhamdulillah done quite nicely and the approach was very good. Just a few points here and there. Did you ask in the history maternal scans done? Or I missed it?
Yeah. No, I missed it. Yes.
I wrote it here. Antenatal ultrasound scans were not
You
asked.
did not ask about the ultrasounds. You asked about fever, I think. You asked about fever, rash, because sometimes these torch infections also can lead to cyanotic heart diseases.
Yeah,
So
I
fever,
asked those.
medication, all that was asked. During birth, you just told about Apgars and everything. Now, when one of your diagnosis is PPHN, did you ask whether meconium stained, not stained, any basic or any high vaginal swab taken for the mother? Just an add. This will not cut your marks, just an add-on points. Basically, this we can put. The neonatal guidelines is saying upper limb is to lower limb saturation difference of more than 5%. I know you, Khidr and Muntasir Raza have given us more than 3%, but the neonatal guidelines, and Dr. Noor, I feel today we should read the cyanotic newborn, even from the neonatal guidelines. It is given just 2-3 pages are there, but in a nutshell, it's given nicely, so it's more than 3%. Blood pressure, normally which blood pressure is
3%, right? Or what you said?
5%. Neonatal guidelines is
5%.
given it as 5%.
In neonatal guideline, it's 5%.
5%. And blood pressure, normally the lower one is higher as far as I know. Please correct me if I'm wrong.
Yeah, it's true.
Yes,
Yeah.
the lower is
Normally
higher,
the
Zana.
lower is higher. So what happens in this whenever like coact and stuff, where the
You
blood
want to
pressure.
tell me the page number of the
Yeah, 49. I remembered for you, page number 49.
Okay, you can continue.
So the blood pressure becomes, if it's lower, the lower BP is lower limb BP is less than the upper limb BP, then we should be thinking of coact and these conditions. You mentioned Alhamdulillah everything in the investigations. Your procalcitonin part was also right. 6 to 8 hours it becomes positive. CRP takes at least 24 hours for us. And sepsis, newborn, anything and everything, sepsis is always one of the differentials as far as I know. So you mentioned about ABC. What was I trying to tell you was in PPHN. Dr. Noor, we can even read after this PPHN. That is also just 2 pages and that will go inshallah very fast. So PPHN, whenever we are explaining just about, as you rightly said, mechanical ventilation, conventional one, then a high frequency, inhalational nitrous oxide. That is the only one which is actually approved. That is a pulmonary vasodilator. And then I was telling you, tell me some more points about ABC. So for even circulation, we can just add on to say that if the child requires appropriate fluid balance, and in this case, what is the problem in PPHN is the pulmonary pressures are more than the systemic pressures. We need to make the systemic pressures more than the pulmonary pressures. So what we can give inotropes, like, dopamine, adrenaline, that all will increase the pulmonary, the systemic pressure. So once the systemic pressure is increased, the cyanosis will reduce because there will be more flow to the lungs. If there is any PDA, any PFO that is open, the shunt across that will also reduce if the systemic pressures are higher. Understood? So just that the requirement of adrenaline, noradrenaline as inotropes. that can improve the systemic INO, inhalation of nitrous oxide will reduce the pulmonary pressure, and adrenaline, noradrenaline will increase the systemic pressure. So just these 2 points. So normally the systemic pressures is equal to the gestational age. If it's a 34 weeker, we say 34 should be the mean. But over here we keep on a higher side. At least the mean should be 50 to 60 and systemic should be, no need to remember this, just telling that systemic pressures have to be higher than the pulmonary is important. It's very difficult to distinguish without an echo between the PPHN and cyanotic heart disease. It's very difficult. So that's why 2D echo becomes very essential. And there are a few points I just forgot. Like, what are the 2D echo findings you can get on PPHN? If it's a PPHN, what 2D echo findings? If anybody wants to just
Yeah, it's going to be right
Hello?
ventricular hypertrophy would be there. And the reversal of the the septum would bulge towards the right side.
Very
And
good.
also the right dilatation of the right atrium and right ventricle would be there. And I think
okay,
yeah,
little
that's it.
dilate, not that great, but most mainly
Then
first, Dr. Faiza will say that the pulmonary pressures will be increased. That's
Yeah,
really
pulmonary
good.
pressure will be high, and if there is shunt, it will be right to left shunt.
there
Okay,
will be
and there is a functional
TRZ and
excellent.
V-shaped heart.
Functional
Yes.
tricuspid regurgitate.
Yeah.
That's why
Yeah.
sometimes we even get a pansystolic murmur in the left lower sternal edge because of this functional tricuspid regurgitate. There is so much of pressure at the in the pulmonary area that it goes backflow and causes this in the right side causes a tricuspid regurgitation jet. So we can even get a systolic murmur. So that's why it becomes very difficult if you do not have an echo to distinguish between both of them. And ECMO, the criteria is it should be more than 34 weeks, more than 2 kgs, no congenital malformation, okay, no big chromosomal abnormality, that the lung should be having a reversible function, okay? It should not be irreversibly damaged. There should not be any big intraventricular hemorrhage, because as it is, that baby is not going to survive. These are few criteria
right.
for ECMO, right?
Yeah, quite right.
So
Quite right.
sometimes ECMO I have seen once a video of ECMO someone was discussing, I don't. So just I thought 1 or 2 words about ECMO that needs to be done.
Yeah, ECMO has a very stringent criteria, and these criteria must be fulfilled before you shift the patient for ECMO. Like the
And
most
there's an
important
entire
thing is
ECMO.
the most important thing is no congenital malformation which is not compatible with life. The children should not go for an ECMO. This is the only thing. The most important
no major
thing.
no IVH bleed. I mean, just think about, you should not have any cause of retardation or disability in the child, and then you go ahead. There's an entire ECMO team that will come into picture after that.
Yeah.
Okay. So I think that is it.
Okay, do you want anything to be read from here, or you want to go to PPHN? This is the page for congenital.
This is 40. I think 40.
The PPHN was completely covered.
Go up. Just a few things which I felt was just this initial, this history investigation, this questions they'll ask us. So just if we could just read about that,
Here, these investigations.
The symptoms and signs also, because that will help us in what will you see in the examination, and what will you see ask in the history, like that.
So from here, a baby presenting with cyanosis or shock is a neonatal emergency requiring consultant input. These babies can deteriorate very quickly. Symptoms and signs of duct-dependent cardiac lesions: central cyanosis or SpO2 less than 95%, poor perfusion or shock, weak or absent femoral pulses, usually limited signs of respiratory distress, murmur in some, that is cardiac murmur guidelines you have to see, hepatomegaly and other signs of cardiac failures. So in the cyanotic baby, this will be central cyanosis and SpO2 less than 5%, and limited signs of respiratory distress will be there. Hepatomegaly and other signs of cardiac failure can be there, and murmur if you can hear.
Last time we had discussed about how that right-sided lesions will come with cyanosis, left-sided will come with shock.
Shock. Yeah.
So that we will not discuss.
Yeah.
I want to add something, please, here. If a cyanotic newborn, first I should decide this is cyanosis due to underlying respiratory problem or it is a congenital heart disease. So there is a test which is called the hyperoxia test.
Yeah.
I
We
think
had
that
discussed
test
that
can
last time.
differentiate.
Very important. This
We had
was
discussed the
very important.
hyperoxia test last time. And in fact, the hyperoxia test, it will, the 100% oxygen will not increase the saturation in both cyanotic heart disease as well as PPHN. Whereas if it's a respiratory cause, it will increase the saturation. Nowadays, there's a controversial role. We had discussed this last time also about the hyperoxia test.
Yeah.
That hyperoxia can, close the PDA if it's a
Yeah, this is
PDA
very
dependent
important.
thing.
You only take the test by the by opinion of your consultant, and like mostly they are avoiding it because sometimes there are duct dependent lesions and the PDA this will close and you will cause further jeopardy to the child. So mostly
Yeah, and
they
as
are
it is,
avoiding.
if you do not have anything in your center, like you do not have a cardiac operation thing or anything, and as it is, you have to refer, you have to start with prostaglandin, and you are giving oxygen at this, so it can be a problem.
Okay. So even though if we mention, we can tell that the controversial thing that it can progress the closure of the duct fast, so better to avoid, right?
Yes.
As other thing in management of PPHN, I think the sedation and the muscle relaxants and sometimes the meconium stent, we need to give pneumonia and hyaline membrane disease. We need to give Cervanta. And the other important thing that if we calculate the oxygen index, it will be important.
This is very important, doctor, but mostly the PICU team is knowing and NICU team is knowing the, oxygen index. This is very wonderful things written here. Na? But
This is will differentiate. It is mild.
Actually, all this is just going to come in the PPHN leaflet now. That's why I didn't explain all this because
Okay,
when
no
Dr.
problem.
will read.
Let's read this and then we'll go to PPN first. Okay. So investigations, chest X-ray. In the chest X-ray, what do you see? Oligemia, plethora, or congenital anomalies. Classic appearance, boot-shaped heart is unusual. Okay. So you can have pulmonary oligemia or even plethora and any congenital anomalies you can see. Blood gas including lactate, very important here. Echocardiogram if available, and we have to mention as soon as possible this one. Once you stabilize the baby, as soon as possible, you have to go for echo to come to your diagnosis. Blood pressure in right upper limb and lower limb, more than 20 mm of Hg difference, but upper and lower between upper and lower limb is abnormal. So tell 20 mm of Hg better because he has mentioned here 20. Okay, difference. Preductal right upper limb, postductal lower limb saturations, SpO2 less than 95% in both lower limbs or more than 3% difference is significant. Okay. So suppose it is 95 in preductal and 91 in postductal, it is significant, right? So
here it is 3% given,
3%
then Dr. Mujna told 5%, right?
Yes,
Where it is 5%?
Just let me just 1 sec. I read it as 5% and I don't know.
Someone
So
also
I think
told
it is
with
my
5%. Someone also told with her 5%. Okay, let's keep reading. Let her search. Modified.
I think, yeah.
There is
Go ahead.
modified hyperoxia test carries risk of duct closure. Discuss with consultant first to differentiate between respiratory and cardiac cause of cyanosis, including baseline saturation and blood gas if arterial line in situ. Okay. So modified hypoxia test you can do, but you have to discuss with the consultant to differentiate between respiratory and cardiac cause of cyanosis, but you should also have a blood gas before that. Place baby in 100% ambient oxygen for 10 minutes. If there is respiratory pathology, SpO2 will usually rise. They can ask you the interpretation of the test, but at the same time, tell the risk of duct closure. So immediate management, suspected cardiac baby presenting collapse, shock or cyanosed is a challenging neonatal emergency. Discuss commencement of prostaglandin infusion urgently with consultant. Discuss urgently with cardiac center. Immediate post-delivery.
I think this much is enough. I think beyond that we have discussed last time the dinoprostone and everything we have discussed.
Okay,
So
no
we can
problem.
go to PPHN if you want.
Tell me the page number.
The PPHN has given 5%. I remember. 286.
Okay, we are here in 286.
One more thing which was not covered in the management was important was treat the underlying cause. If it is sepsis causing PPHN, then treat the sepsis. And pneumonia causing, treat the pneumonia. If it's causing aspiration, then like as
Basically,
doctor, one doctor was saying surfactant to be given.
Whenever the thing is that, like if it's PPHN, you have to treat all the causes combined together. First of all, you have to, nurse the baby in a very quiet room, minimum handling, no immediately past the central line, umbilical and arterial line. Okay, sedate, relax the baby if the child is going to be going on invasive ventilation. Okay, and then you have to give the antibiotic for congenital infection. If there is prematurity or ARDS secondary to surfactant deficiency or meconium aspiration syndrome, you can give a surfactant. And then along with all these things, then you start off with this what is this thing called? This inhaled nitric oxide and all that stuff.
Okay. So now I will read these clinical features, investigations and management here. Okay, Dr. Muznaf, for the PPHN. Okay.
Yeah.
So clinical features usually present in first 12 hours of life. So your patient, what was the age you told?
18 hours.
12 to 18 hours, I said. Yeah.
Okay. So it will usually present in first 12 hours of life. SpO2 less than 95% or hypoxia, and PaO2 will be less than 6 kilopascals in 100% oxygen. So though you are giving 100% oxygen, you will see these values in the ABG, and SpO2 will be less than 95%. Mimics cyanotic heart disease. So you will put both as the differential. CVS, tricuspid regurgitation murmur, right ventricular heave, loud second heart sound, and systemic hypotension. Idiopathic PPHN, respiratory signs may be mild or absent. Secondary persistent pulmonary hypertension, features of underlying disease. Okay, in idiopathic, you can have some mild respiratory symptoms or no respiratory symptoms, but in secondary, you will have the underlying cause disease. This is the symptoms you can see. But here I want to ask, this tricuspid regurgitation murmur, this is all due to the increased flow on the right side, right? These are flow murmurs or what?
Yeah. No, this is because of
the increased pulmonary vascular pressure. What is happening? The right ventricle is unable to pump the blood in the pulmonary artery because of vasculature. There's a lot of resistance.
Yeah.
So because of this difficulty, what is happening? There is backflow that is happening, and this is tricuspid regurgitation murmur. Whenever the right ventricle is trying to, now just imagine the right ventricle is trying to pump. Okay, there is so much of resistance up. So what is there? There'll be no blood going in the lung. All the blood will going up. Will be going upwards. In the tricuspid valve area.
Okay.
Exactly. It will be regurgitated.
And also you see right ventricular heave, because you said there can be right ventricular hypertrophy, but it will not develop so early, right? Because in the beginning of the problem.
Hello. See, in the PPHN, there is a right to left shunt through the foramen ovale. And then there is increased blood coming to the right side. That will be the cause of cyanosis. And then it will come to the right ventricle and cause right ventricular pressure increase. And that is the reason for the murmur.
Regurgitation murmur. Okay. So next, investigations, blood gas shows hypoxemia, PaO2 less than 6 kilopascals with oxygenation index more than 20. Underlying disease will produce a mixed picture. Okay, so we can remember this in the blood gas. Okay, I don't know about this oxygen index. Anyone knows?
They are giving down oxygenation index. How to calculate is given down.
Okay.
This is basically done by blood gas, and mostly children or vents, they are going for it. No need to work hard on it. This is purely ICU medicine. Even the examiner won't know about it. I can bet on it.
Okay, SpO2 more than 5% difference. Here it's given. Preductal right hand and postductal saturations either feet, pre more than post. So here it's given 5%. I don't know why he's given particularly for PPHN or what?
Yeah, this is that 3% is, I'm sure, that is the difference we'll consider for any coarctation and all. Okay. That is what they consider. But here, baby PPHN, they are taking more than 5%.
Maybe.
Actually,
Yeah.
in the books, most of the books I have seen, it is 3 to 5%. I mentioned.
Okay, so better when we are, if the examiner takes your discussion towards PPHN, tell 5%. If he takes towards cyanotic heart disease, tell 3%. Okay. So SpO2 more than 5% difference in preductal and postductal. Hyperoxia test 100% oxygen for 5 minutes. SpO2 may improve to more than 95% in early stage or may not respond. That is
Dr. Noor, one more thing. In the bracket, you can see pre more than the post. Maybe in PPHN, they are having pre more than the post. Normally, the lower limb is more than upper limb, right?
No.
Lower limb blood pressure is more than upper limb. This is saturation. Normally, this is differential cyanosis, which is there.
Okay.
So this is saturation. So saturation may upper is more than the lower. So whenever upper is more than the lower, this is differential cyanosis. So we have these two DDs, PPHN and coarct.
Yeah.
Next is we were reading about SpO2 sometimes can improve with your hyperoxia test in early stage or may not respond, that is staying less than 95% in established PPHN as in cyanotic. So sometimes it can go up in early stage, but in established PPHN it will be less than 95%. Chest X-ray variable findings depending on underlying diagnosis. Normal or minimal changes in idiopathic. Usually in idiopathic, it will be normal. In underlying causes, you will see the picture of that. Electrocardiography, often normal. Sometimes show tall P wave in lead V1 and V2 or features of RVH. Tall R waves in V1 and V2 and right axis deviation and upright T waves. That is features of right ventricular hypertrophy you can see. Okay, and also tall P waves like P pulmonale. Okay,
so that indicates increased right atrial pressure.
Yeah, so you see tall P waves, P pulmonale, or features of RVH like tall R waves in V1 and V2 and upright T waves in V1 and V2. Echocardiography, although not mandatory for initial diagnosis and management, is useful to exclude heart disease. So echocardiography is necessary because for your differential diagnosis, and also to assess pulmonary pressure and to evaluate ventricular function. These are the three reasons. To rule out cyanotic heart disease, to assess pulmonary pressure and evaluate ventricular function. More than one of the following confirm PPHN in presence of normal cardiac structures: significant tricuspid regurgitation, dilatation of right side of the heart or hypertrophy of the right ventricle, right to left chanting across the foramen oval or PDA, pulmonary regurgitation, flattening or bowing of the interventricular septum towards the right ventricle. Okay. Most of these points we discussed when we were talking. So pulmonary pressure is estimated from echocardiogram using either tricuspid regurgitation and pulmonary regurgitation.
No need to go for it, Doctor. No need to go. This is cardiology, pure cardiology, pure.
Okay. Management, if saturations continue less than 95% despite 100% oxygen and echocardiography is not available immediately to rule out duct-dependent heart disease, start prostaglandin IV. Suppose you're in a remote place where you don't have an option of doing an echocardiography to rule out duct-dependent lesion, and the saturation is less than 95% despite 100% oxygen, you can start prostaglandin IV, he is telling. Once PPHN suspected, inform and involve consultant neonatologist immediately. Aims of management are to decrease pulmonary vascular resistance, increase systemic blood pressure, and treat any underlying conditions. So these three you have to tell. Decrease pulmonary vascular resistance, increase systemic blood pressure, and underlying cause. General measures: minimal handling, nurse in quiet environment, secure arterial and central venous access. See arterial, okay, this one. Maintain normal temperature, biochemistry and fluid balance. HB, keep HB more than 120 grams per liter.
This is 12, basically 12 grams.
No. He's telling per liter. If you calculate for deciliter, it will be 12, right? Yeah. Give antibiotics if you are suspecting sepsis, particularly GBS is difficult to exclude. Surfactant may be beneficial in meconium aspiration syndrome or GBS sepsis. Discuss with consultant. If poor perfusion, fluid bolus 0.9%, 10 ml per kg, or if coagulopathy, fresh frozen plasma. Once PaCO2 is acceptable range, that is less than 6 kilopascals, correct metabolic acidosis to maintain pH between normal. Okay, use full correction with sodium bicarbonate over 1 hour. If repeat correction necessary, slow bicarbonate infusion and calculated dosage over 6 to 12 hours. Okay, next is the general measures. We can just remember this. These are the main things. I'll just mute all because I have some background noise. So minimal handling, and you can secure the arterial and central venous access. Maintain temperature, biochemistry and fluid balance, antibiotics and surfactant if you suspect GBS sepsis and MAS. Otherwise, you can also tell the ABG, you have to bring the acidosis to normal. And this is PaCO2 less than 6 kilopascals, he is telling. Before he was telling what? PaO2, right? Okay, PaO2 was less than 6, but we should bring PaCO2 to less than 6. That's what he's telling, right? I have muted all. If anybody is...
Yeah.
Okay.
So basically, hypoxia should be prevented, hypercarbia should be prevented.
Yeah, this is basically pure PICU, pure neonatal ICU. I mean, you should know the basics only. I mean, they won't go into that detail. I mean, just 5 things, remember.
We can just tell the headlines, like how ABC and nurse in a quiet environment. Okay, analgesia.
Okay, go ahead.
And then after that, we can just say conventional ventilation required. If still not maintaining, we may require with consultant's opinion, high frequency or inhalational nitric oxide or inotropes to increase the systemic vascular resistance. If still resistance and ECMO, just tell name of the headlines rather than...
Just we'll remember the headlines. I don't think they will ask.
No, they will not ask. Just ECMO also, I asked because ECMO videos do come. I don't know.
Okay. Because there is no time. In 6 minutes, you will tell what history you will take, what examination you will do, what investigations you will do, and what differential diagnosis and management. So but we should touch all the headlines here. All headlines is very important. Okay. So just we'll go through the headlines finished. I'll just read for criteria for ECMO here. Okay. Baby born more than 36 weeks or more than 2 kg with PPHN, oxygen index
34 weeks.
Yeah, 34 weeks. Oxygen index more than 40, reversible lung disease, that is less than 10 days, high pressure ventilation, no lethal congenital abnormality, malformations. Okay. Then exclusion criteria, if in doubt, discuss with ECMO team. Okay, if you have any doubt, you have to discuss. What is it? Major intracranial hemorrhage, Irreversible lung injury or mechanical ventilation more than 10 days. Here he said less than 10 days you can go. But if it is more than 10 days, you have to discuss with the ECMO team. Lethal congenital or chromosomal anomalies, severe encephalopathy, major cardiac malformation. Okay. I think enough, right? Anything else you want to cover, Dr. Muzna?
No, I think more than enough. More than
Yeah,
enough.
for this management and this general measures, let's all make the heading points. No need to tell the values. Maybe for pH and this we can know it's better because we will be doing ABGs commonly. Even in our setup. So other things and all, just remember the headings, make the headings and just answer. I think more than enough, both in congenital heart disease and here. So we are done with this video. Anyone has comments? Please go ahead before we go to the next. Okay, no comments. So Dr. Sridevi, 3% and 5%. Just remember, huh?
Okay.
Yeah. Okay. We will go for the next case, but just only 5 minutes break, huh? Just 5 minutes. I will be connected to the meeting, but maybe in 3 minutes we will start.